this video, we're going to focus on malaria and review a number of anti-malarial drugs that are commonly used or ones that you should at least be aware of, focusing specifically, of course, on the pharmacology for these agents, the important considerations if you choose to use them, and strategies to place these agents into different buckets and group them together to help with the learning of them all. And to start off, we're going to do a brief overview of our culprit parasite, which is going to be the Plasmodium species. And we're going to start off by going over this parasite's life cycle. Now, for this video, we're going to discuss the Plasmodium species as a whole, so grouping them all sort of together with some generalizations. But just know that there are going to be differences and nuances with each species, with the big four being Falciparum, Malariae, Ovale, and Vivax. But this will be a good foundation, and then in IQ you can sort of fill in the finer details like differences in this life cycle and sensitivities and resistant patterns. Now, the life cycle of this parasite is going to begin with the bite of an infected female mosquito that's going to inject Plasmodium sporozoites housed in the salivary glands during a blood meal into its victim. Now, these sporozoites enter the bloodstream and circulate until they reach the liver, where they invade and infect the hepatocytes. Okay, and this is called the exo or pre-erythrocytic stage of the infection. And while in the hepatocytes, the parasite is going to undergo asexual replication until it eventually results in the formation of a liver schizont. And this is eventually going to rupture the hepatocytes, and it's going to release a bunch of merozoites into the bloodstream. So now, for certain species, there may be some residual parasites that can take on a quiescent or dormant state and become hypnozoites, which can reemerge as a later infection long after that initial infection. So keep that in mind. But then moving back to our released merozoites into the bloodstream, that can now go on and infect our red blood cells or RBCs, starting the erythrocytic stage. And this is the stage responsible for that clinical presentation of malaria. So inside the red blood cells, the merozoites eventually mature into hemoglobin digesting or metabolizing trophozoites and further mature to eventually become a blood stage schizont. This is eventually going to cause rupture of that red blood cell and the release of new merozoites into the bloodstream to continue the cycle over and over again, leading to what you might predict with hemolysis and anemia, along with flu-like symptoms from the infection. Additionally, these can mature into gametocytes that can be picked up and spread to the next mosquito that bites this individual, restarting this cycle all over again. So moving to the next slide. And the reason we went over the life cycle of malaria parasites is because grouping the antimalarials by which stage in the life cycle they hit is really helpful. So we will go over this grouping strategy now on the next slide. And then as we discuss the pharmacology of all these agents, some of this targeting will make much more sense. Because one thing that makes this grouping strategy easier is by knowing how the drugs actually work. So just keep that in mind, and let's move to the next slide. So we're going to start off with this erythrocytic stage because this is where the majority of agents we're going to talk about today work. And remember, this is the stage where we have this asexual replication cycle happening within the red blood cells. So the first class of drugs we'll talk about in this sort of category that target this stage are going to be the quinolines, or you might hear them called quinolins. Either one's fine. And they work here. This is going to include agents like chloroquine, quinine, quinidine, mefloquine, tafenoquine, etc. We also have the artemisinins. We have atovaquone and proguanil as a combination. We have sulfadoxine and pyrimethamine as a combination. We also have doxy and clinda here listed as well. Now switching gears to see which target the pre-erythrocytic stage that occurs within the liver, again focusing on this asexual replication. These would be primaquine, tafenoquine, atovaquone, and proguanil as a combination. Then we can come over here to talk about the drugs that are actually going to target these hypnozoites, and this is going to be primaquine and tafenoquine. And then lastly, we're going to come over here and talk about our drugs that potentially target our gametocytes, and this is going to be tafenoquine, our artemisinins, and then potentially our primaquine. And again, this is just a general overview, and I do want to highlight there is going to be nuance based upon which species of Plasmodium you're talking about, which resource you're looking at, and which region you are looking at, and based on those sensitivity and resistance patterns. But this is a good place to start. Now we'll come back to this grouping based on life cycle stage, but another really helpful way to actually group all of these classes is into two different bins. So the first bin is going to have all the classes that work through the generation of reactive molecules that are going to broadly damage essential cellular components. And then the second bin is going to just be all of the other agents that have more specific or targeted mechanisms. So we're going to move on to this grouping strategy to give more context to this grouping by life cycle stage. So moving to the next slide. But before we dive into our first class of agents, we need to talk about hemoglobin and the parasite that is in the erythrocytic stage. And in this stage, what happens is, in order to replicate, the merozoites mature into a form that is able to metabolize hemoglobin in the red blood cells. And what happens is that hemoglobin is transported into the parasite's food vacuole, where it is digested to produce amino acids that can be used in protein synthesis during this asexual replication process. But also, this is going to generate heme, and this is highly toxic to the parasites. So they have a built-in way to convert this heme into an insoluble, chemically inert hemozoin. And ultimately, there's no harm, no foul. They can continue to metabolize that hemoglobin and continue that replication cycle. So moving to the next slide. And this is important because we are first going to discuss the class of agents known as the quinolins. Now, there are a few subclasses within this superclass of quinolins. We have the 4-amino quinolins. We have the 4-methanol quinolins, and then we also have the 8-amino quinolins. And we're going to start by grouping these first two subclasses together. This is going to include agents like chloroquine, quinine, and quinidine, methylquine, and lumefantrine, and a handful of others. And how all of these agents are thought to work is by first accumulating within the food vacuole of the parasite, and then forming some sort of complex with or interacting in a not fully understood way with heme to essentially prevent it from becoming converted into that insoluble inert hemozoin form. And remember, heme is toxic to the parasite and very reactive, so it goes on to generate reactive oxygen species and oxidative damage that destroys parasite membranes and other essential critical structures, eventually leading to parasite death. And if you think about this mechanism of action, you can infer that this reliance on heme means that these agents are going to be effective for parasites in that erythrocytic stage, but not in the others. So important farm considerations are going to vary between the different agents, but there are a few to take note of. For chloroquine, this was the first drug that was used pretty broadly for malaria treatment, and many of the others within this class are very similar in structure and were generated after. And because of that, chloroquine and the others have a very large volume of distribution, meaning that it is sequestered in the tissue, so if a toxicity occurs, it's probably going to be prolonged, and it's not really going to be helped by things like dialysis, for example. So the side effects of chloroquine are typically going to be headaches, GI distress, and pruritus. But this can also go on to include things like neuromyopathy, retinopathy, and bone marrow toxicity. But these are rare. So then if we come down to quinidine and quinine, we see a risk of QT prolongation and arrhythmias. We also see the risk of hypotension and hypoglycemia, because these drugs are known to actually stimulate insulin release from the beta cells. And there's also this characteristic synchronism, which is a combination of tinnitus, nausea, headaches, dizziness, and disturbed vision. Now, these do have CYP3A4 metabolism, so opportunities for drug interactions, as well as a narrow therapeutic window, and again, a very high volume of distribution and tissue sequestration, and overdose can cause cardiotoxicity, blindness, and deafness. So lots of considerations with these two. Next agent we're going to talk about is mefloquine, and this is going to be the last specific agent we're going to mention. So for this one, the side effects are going to be GI. There's also going to be some dizziness, some sleep disturbances, and there is also going to be concerns for QT prolongation and arrhythmia. Now, this agent is going to be contraindicated in those with psychiatric or neurological issues, and it's also going to be contraindicated in those that have a family history of things like seizure and psychosis risk. There is also mefloquine-induced pneumonitis. And then lastly, the main mechanism of resistance for these quinolines is going to be transporters that are regulating the entry of drug into the food vacuole to hit their targets. Now, the other subclass of quinolines we haven't talked about, the 8-aminoquinolines, are going to include agents like primaquine and tafenoquine. And the exact mechanism of action of these agents is not fully understood, but they may potentially still retain some of this typical sort of quinoline mechanism we just discussed for the others, and or they may undergo activation, so prodrugs activated to their active form by CYP2D6 to more reactive metabolites that can go on and cause damage to the mitochondria, leading to a reduction in ATP, triggering cell death, as well as damage to other structures in the cell to help contribute to that effect. Now, primaquine, for instance, is thought to act more through this mechanism where it's the prodrug that's converted by CYP2D6 to those reactive species, leading to that damage to the mitochondria, and less of this sort of typical mechanism for the quinolines that we already described. And this is because it's not as good at treating those erythrocytic stages, but it is much better at those hepatic stages. For instance, it is able to target those hypnozoids, for example, where that CYP2D6 conversion would actually happen, right, in the liver. And we've also know that individuals that are poor metabolizers for CYP2D6 have been shown to have a higher risk of therapy failure with primaquine. Whereas if we come up here to tafenoquine, the story is a little bit different, where we might have more of this traditional quinoline mechanism that we talked about before, and we might still have this mitochondrial targeting with these reactive species. However, that CYP2D6 activation may not be needed to achieve this effect, and this is because we know it is more effective in the erythrocytic stage, as well as still effective in the hepatic stages, and it seems that CYP2D6 status is less of a contributor here. Now, besides these mechanistic differences and the fact that tafenoquine has a much longer half-life than primaquine, they are very similar, so checking for glucose 6-phosphate dehydrogenase deficiency, or G6PD deficiency, is going to be essential prior to use due to the risk of hemolytic anemia, and there are dosing adjustment recommendations available for those that are deficient in this enzyme. There is also going to be arrhythmia risks with this particular two agents, so identifying or minimizing any risk factors for those is necessary. And there's also going to be a risk of methemoglobinemia, and the common side effects are really GI distress, as like most agents, and this can be minimized when taken with food. Now we're going to move away from the quinoline derivatives and onto the artemisinins. And an example of this would be artesunate. And these drugs are going to work as prodrugs. And what's going to happen is they are going to come into the food vacuole and they are going to interact with the heme within the parasite that has accumulated. And this is going to generate free radicals and oxidative damage to the membranes and to other essential cellular structures, and again destroying the parasite. As we saw before, this is again based on this heme and hemoglobin reliance, and you can infer that this is going to be most helpful in erythrocytic stages. And in fact, it is extremely effective treatment for malaria. And of course, we want to minimize resistance to our really effective agents. So a lot of times you might see this as an artemisinin-based combination therapy, or see it abbreviated as ACT. Now, because they are so effective, you might see patients have post-treatment hemolysis, but generally they are well tolerated. Sometimes hypersensitivity reactions can occur, and resistance to these agents is thought to mainly occur through the upregulation of oxidative stress response pathways in the parasite. Moving to the next slide. Now, as I mentioned, we focused on the antimalarials, whose mechanism relied upon the generation of reactive oxygen species and metabolites able to more broadly destroy parasitic structures. So now we're going to turn to agents on our next slide with more targeted mechanisms. On this slide, we're going to start off with the most unfamiliar agents and work our way to more familiar ones. So we will start focused on the mitochondria, where within the electrotransport chain of these parasites, we have the cytochrome BC1 complex, which I'm showing you here. And this is essential for obviously the generation of ATP, but also it supplies ubiquinone for pyrimidine synthesis within the mitochondria. So atovaquone is our next agent that we're going to discuss, and this actually binds to and inhibits this cytochrome BC1 complex, thereby inhibiting electron transport and the generation of ATP, and interferes with pyrimidine synthesis in the mitochondria. So because there is enough difference between the plasmodium and the human proteins, there is this sort of selective toxicity to the parasite. And I like to think of atovaquone targets mitochondria most likely in the most replicating stages for the parasite. So it'll be really helpful in the erythrocytic stage and the hepatic stage, where we have that asexual replication. Again, some nuances with species, but a good place to start. So for side effects, it can cause headache, rash, GI distress. Food can help, and absorption can be improved with food. And there can be some increases in LFTs, but these are typically transient, and resistance is typically thought to be through mutations at that target. Now, atovaquone is typically combined with the agent proguanil, which is going to direct us back to this very familiar pathway of folate metabolism that is going to funnel down to purine and pyrimidine synthesis, and then eventually to this formation of DNA. So proguanil gives you a hint that it is a prodrug within its name. So it needs to be converted to its active form of cycloguanil. And then once in this active form, it can actually inhibit dihydrofolate reductase. And for the parasite, this enzyme also serves as the thymidylate synthetase. So our active form is going to inhibit this enzyme and interfere with DNA synthesis, eventually causing parasite death. So this agent is also thought to potentiate the effect of atovaquone at the mitochondria, so another reason as to why these two agents are combined together. So as you might guess, resistance is usually thought to be due to mutations in this particular enzyme target. So now for our next two agents, we're going to continue to focus on this folate metabolism pathway. And hopefully this has jogged your memory about an antibiotic called Bactrim, which was a combination of sulfamethoxazole and trimethoprim. Now, what we can do in the parasite, we still have a sulfonamide up here, but now we have sulfadoxine. And down here, instead of trimethoprim, we have pyrimethamine. Where our sulfadoxine is now up here hitting this first target at dihydropteroate synthase, and then we get that second hit in this pathway with pyrimethamine targeting that dihydrofolate reductase. Now, because sulfadoxine and pyrimethamine are less common than a lot of the other agents we talked about, and they have a lot of overlap with Bactrim in terms of important things to note, we're not going to spend too much time on them, but some things to note that are, again, common with Bactrim would be things like GI side effects, severe cutaneous reactions like Stevens-Johnson syndrome, avoid and sulfa allergy, and as for resistance, these agents, you would probably expect these target mutations in these enzymes to be the most likely mechanism. And then lastly, we will focus on another very familiar mechanism of protein synthesis, and we won't spend too much time on this because this is going to be incredibly similar to the bacterial ribosome, which we can target and inhibit protein synthesis with some agents you have already seen before and you should be familiar with. So tetracyclines like doxycycline prevents a tRNA access, and clindamycin, which is a lincosamide antibiotic, is going to prevent addition of the peptide chain to the next amino acid. So both are going to inhibit protein synthesis, leading to eventual parasite death, but these effects do take a lot of time. So since these we have already covered in depth, we're not going to spend any additional time on these, but same important pharmacologic considerations apply from before. So moving to the next slide. Now that addresses all the antimalarials that work through more targeted or specific mechanisms essential to the parasite's survival versus the quinolines and the artemisinins that lead to the generation of reactive species that more broadly destroy cellular targets. So moving to our final summary slide. So this concludes our discussion of antimalarials, and I hope this video has provided insight into how we can use the pharmacology of these agents, especially the mechanisms of action, to better understand where these agents hit the malaria parasite's life cycle. Some are more helpful than others, and also why we typically need to combine agents together and have options from both a resistance perspective, but also to make sure we ensure therapeutic successes as best we can and limit treatment failures. And then pharmacologic considerations, just like we discussed with antibiotics, will be super important so you can set realistic expectations with your patients to help boost adherence to further minimize any treatment failures and adverse outcomes.